Good afternoon and good evening, everyone. Welcome. Thank you for joining us today for today's webinar. My name is Lawrence Chia, and I am the Business Marketing and Sales Leader for Image Guided Therapy ASEAN and Pacific for Philips Healthcare. Today, we have prepared a very interesting session on sustainability of COVID-19 in-hospital measures and patient selection in endovascular treatment, a multidisciplinary view. We are privileged to have this session moderated by Professor Tay Kian Hiong, Head of the Vascular and Interventional Radiology Department, Singapore General Hospital. Just a little housekeeping before we get started. If you have any questions during the presentation, please type into the Q&A box in the meeting control panel. Questions will be answered during the Q&A sessions towards the end of the webinar. At any point during the webinar, you may click the pause button to pause the event or click live to watch it real time. This webinar will be recorded. Now, without further ado, we will turn over the time over to Professor Tay.
Thanks, Lawrence, for the kind invitation and kind introduction. Today we have three distinguished speakers from the three specialties of interventional cardiology, interventional radiology, as well as vascular surgery. So we will try to have a short Q&A in between the speakers, but I guess depending on the time, we may have that question and answer at the end of the presentation. So without further ado, I would like to introduce the first speaker. He is Dr. Chao, Senior Consultant Interventional Radiologist at the Singapore General Hospital. He is currently also the Deputy Head of Department and the Director for IR Ops. He will speak to us on the current measures in IR for the COVID-19 pandemic. Chao, please.
Hello, thank you very much. Okay, can everybody see my screen?
Yep. Yes.
Okay, so let's continue. So we're going to talk about COVID-19 and the angio suite and really where are we now in the pandemic. I think everybody has seen this graph many times. It describes the way of mitigation as well as what happens after the mitigation and the dance. The world has closed. It is slowly reopening in some places, and certainly in Singapore, we think that we are here. We have reached our peak and the cases are slowly coming down. And the phase 2 has been announced just last week with the slow progressive opening of our society. Now, really the preparation of the IR center, it is a cycle, isn't it? You formulate protocol, you want to sustain practice, you adapt, and then you change the protocols again. And we're going to talk through some of that today. Just to give everybody some context, SGH is an old building, and that really affects what we do. 1,700 bed is big. We are the largest vascular and interventional radiology department or section in Singapore. We have 7 rooms that's across 2 floors, so that logistically also gives us some headache, but as well as some bandwidth. It is a multi-site service, as I'll explain a little bit later, whereby the IRs rotate to the KK Women's Children's Hospital as well as the Sengkang General Hospital to support the services there. Now, some lessons that we learned from phase 1, and phase 1 is our circuit breaker or our lockdown. From the start, you need to work with other stakeholders to come up with a workable plan. The angio suite workflows should be incorporated into the rest of hospitals, simply because infection controls need to help bring your patients from the ward to the IR suite. Anesthesia is needed to maintain airway, environmental services is needed for cleaning the place after that, and security is needed for crowd control. So when we plan our own workflows, we cannot plan alone. We need to get our staff familiar and confident with the protocols. I cannot stress this enough. And we want to document those protocols for clarity and reproducibility. Now, so as we enter phase 2, when we are slowly opening up, so what are we going to do? How are we going to treat more patients while keeping the virus at bay? So now we're going to go through some of the current measures. Now, we need to have continued infection prevention vigilance. So for inpatients, we will continue to wear masks. Everybody in the hospital wears a surgical mask unless they are seeing isolation patients. Strict hand hygiene protocol is still needed. Now, in the hospital, we then divide our patients into 3 groups. So first, for routine patients, surgical mask is enough. for patients that has acute respiratory infection before they are cleared of the COVID swabs, and or when we are doing aerosol generating procedures like feeding tube insertion, lung biopsies, we need to wear N95. For COVID patients, whether it's suspected or confirmed, it's the full works, N95, full PPE, and a stepped up cleaning regime that includes UVC raised disinfection. So again, this is one of the cases that we're doing for suspected COVID patients. As you can see, everybody's in PPE, face shield, N95. I'm not too sure if you can see properly. Whatever equipment that we can wrap, we'll wrap it up. The ICU team who handles the airway are in PAPR. We are just doing with the N95. A pro tip that I find recently, so now, once and again, you have a suspected COVID patients that get admitted in the hospital deep in the night when documentation is poor. You don't know whether this patient has COVID, don't have COVID, how is the suspicion level? So my tip is really to call the in-charge consultant in the hospital to clarify the isolation status so that we don't make a mistake when we bring down the patient to do emergency cases. Now, for outpatients, we try and see our patients on the same day as they're referred. Bear in mind that we are a public institution, so previously this is not easy to do. We screen all our patients before they come into the clinic, so those patients with fever picked up by the screening will be isolated. This is example of how we do our screening, the criteria and what we do. So this is released as routine instructions from the hospital. Now, there are some people talking of wherever you're admitted to the hospital or you come for procedure, you get a swab test, especially in the United States. We are not there yet. So certainly we will screen based on questionnaire rather than to get to swab everybody. Now, for continued infection prevention for outpatients, we call all our day surgery patients the day before and again screen them on the questionnaire. If they have any fever, we ask them to postpone and to seek help somewhere else. We don't mix our in and out patients just to keep the pool separate. Now, we have realized that we need to move less from segregation, which we did during the lockdown, to more physical distancing. During the lockdown, we had Team A, Team B, who runs upstairs, downstairs, although it is not very successful, really because of the different number of rooms and the case mix we have. Now, complete team segregation has an impact on turnaround time. It is really not easy to maintain in a procedural unit, and it's not workable in the long haul. If you have some, key specialist that is on MC, and then this whole thing breaks down. And hence, physical distancing within the department is very important. Masks are still mandatory. As you can see, even if they're in the same room, we try and keep our distance. So this is a floor plan, and when you find more space, do use it. So recently, the National Heart Center has vacated these cath labs in the department, and that allow us to spill some of our work over to the other side before further renovations are used. Now you can see this is our department, and it's very busy, and this is room 2, and this is a dedicated biplane neuro room. So we've decided that when neuro don't need this and we don't need this, we'll close this room for physical distancing. And this is some of the measures that we go to ensure that the people are properly spaced apart. Waiting areas are marked out so that the family members don't sit too close together. We have separated our pantry dining rooms. It may be a bit small, but there's a perspex glass here separating the 2 rooms. Our reporting rooms, thankfully, we have at least 1 to 1.5 distance between them. We have certainly moved some machines out to make sure there's a bit more space. So again, these are things that we need to do to ensure better physical distancing. This is a more elaborate gesture. This is one of, we have converted one of the meeting spaces in the hospital for dining for the rest of the staff. Whenever I see this, I think a little bit like Gattaca, the scenes in Gattaca, which is one of my favorite sci-fi movies. It's quite dystopian. Everybody is behaving like a dystopian future. However, we keep the teams in place in case there's a need for further segregation again. Now, previously, we have covered KK Women's Children's Hospital in Sengkang on a weekly rotational basis. That has stopped. We have actually dedicated manpower there now. So this is again to reduce the mixing of the different institutions. And this is really to make sure that when we are locked down again, we have a plan. So this just came in literally when I was surfing Facebook before the talk, and we know that Beijing is locked down. So there's a very high chance that even if we open up, we'll get locked down again, and we need to be prepared for that. Now, we want less contact time for patients and staff. So again, we have spoken about the same day clinic consult in the VRR clinic. We want more day surgery procedures so that we don't admit the patient. We want to leverage technology. We want to do more video consult with our patients. We want to do remote scheduling and listing so that our patients don't have to wait further in the hospital, and we have Zoom MDTs and meetings. So for example, this is our lung biopsy protocol that we just launched last month, and it's really, we had this for some time, but we decided to launch it while we have after the circuit breaker so that we reduce the number of inpatient stays when we can. Zoom family conference, we have started this recently as well. And I think this really gives an extra peace of mind when we want to reduce the number of footprint in the hospital. At least we can get a good consultation. And this was a really complex case of pain management in an elderly patient. And Zoom meeting, so this is me having fun with a virtual background, and this was from our recent retreats that we have. So all 16, 18 people tuning in via Zoom to have a meeting. This is the new normal. Staff morale is something that we really want to keep up. Now, I cannot stress that if you have good protocols, well thought out procedures, and we instill confidence by planning all the COVID-19 cases that we do, rehearsals and after action review, this is the best way to actually boost staff morale so they don't feel that they are in danger or in peril. The staff needs rest, fatigue equals shortcuts, and we want to ask how individuals are coping just to make sure that we're not missing something out. We have previously published this, how we treat COVID-19 patients in CVIR. I urge all those to go and take a look if you think that you still need something to do. But everything was meticulously planned out. So when we have a COVID-19 patient, we actually map out exactly where each of our staff members is supposed to be and where all our cleaning, our PAPR, and our PPE donning and removal is supposed to be. We write it all out so that people can look at it if they forget. And even when we go to the ICU and the order of the doctors and the nurses moving in and out of the ICU, we want to get that ready so that people can be ready. In conclusion, the new normal is here. We need to guard against the resurgence of COVID-19 while trying to do our usual stuff. Good protocols, infection control, and physical distancing is the key. We need to be nimble, and certainly we need to plan for further lockdowns. We need to have less resistance to trying new things, video consult, day surgery, and you'll find that it's during these times whereby the hospital administration may be more ready to try new things that we were trying to push years before. We find they move faster now. We need to consolidate and adapt. And this really leads me to thank everybody from my team who I think has done a really good job so far handling the pandemic. And thank you very much.
Thank you, Chao, for that comprehensive review of the measures taken at SGH. I think I don't see any question on the Q&A yet. So for those who have just joined the webinar, just to remind everyone that to ask question, you can just use the Q&A tab to ask the question. I believe the next speaker will be talking on something similar, so maybe we will let Dr. Edward Chok do his talk and then we do the Q&A. So it gives me great pleasure to introduce Dr. Edward Chok. He's a senior consultant, vascular and endovascular surgeon at the Sengkang General Hospital. Eddie is a prolific researcher. He had more than 100 publications and has won numerous research awards. So this evening he's going to speak to us on prioritization of vascular cases and perioperative workflow during this COVID-19 pandemic. Eddie, please go ahead.
Thank you very much, Prof. Tay. It's always a pleasure and really a kind introduction. Very pleased that, even though we are about 30 miles apart, I'm still able to see you guys electronically. We've been segregated for the last, God knows, I think maybe 4 months, so I've not had a chance to come to SGH. So really, really nice to see my esteemed colleagues again. So I really wanted to talk about how we prioritize our vascular cases and our perioperative workflow during COVID-19. So this is the basic algorithm. When we first heard about the potential pandemic, this was back in early January. We started the Wuhan task force in Sengkang General Hospital in the General Surgical Group to try and come up with ways with which we work around this potential, at that time it was a potential pandemic. So this was our algorithm for the whole of general surgery. And this also blended in nicely with the circuit breaker that came afterwards. So the first question we ask ourselves is the service essential? Okay, whether it's non-essential or essential. If it's essential, then we will go ahead and do the operation. So how do we classify whether the service is essential or not, i.e. the operation? Any patients with severe symptoms, pain usually, we will do the operation. If they have no symptoms, then we ask the questions if it is potentially life-threatening if we do not do the operation. So we came up with 3 tiers: tier 1, tier 2, and tier 3. Essentially, tier 1 you must do. Tier 2 you would consider postponing. Tier 1 you do them if you have large AAAs, thoracic aneurysms, critical ischemia, obviously to save the leg, and any symptomatic carotids. In tier 2, mostly are the dialysis access patients, so creation and salvage, because this is the lifeline of our end-stage renal failure patients. Tier 3 patients, we will postpone, unless if they are really in severe pain, which is quite rare. So venous insufficiency, they come in with a bit discomfort. They're not really in severe pain. So for those, we have not been doing any vein operations for a long time. Asymptomatic carotids, postpone. Claudicants, postpone. Even those that are life-limiting, we actually ask them, come back after the pandemic. And slowly we're beginning to open. And the reasons why we do this is for 2 reasons, really. We really wanted to conserve our PPE and our equipment, because you never know, at that point, how bad this pandemic is going to be. At that point, our N95 masks are all in a potential shortage. So we wanted to conserve all equipment and PPE. We also wanted to conserve staff, because at the moment we've got a huge problem with the migrant workers, and a lot of our surgical colleagues, our physios, they're all deployed. Our scrub nurses are deployed to the dormitories to do swabbing. Even as we speak, they're all in the dorms performing swabbing exercises, trying to contain the spread of the COVID-19 through the migrant worker population. So this is really the underlying reasoning behind this thinking. We followed, in terms of vascular, we followed the American College of Surgeons guidelines very closely, with some adaptations. So this is their kind of guidelines. In this category, AAA, they classify them into tier 1, 2, and 3, in which tier 3 is do not postpone. These are the ruptured symptomatic AAA, any infected aneurysms, those you must do. The other classification which they will consider postponing are AAAs more than 6.5. But I must say, in Sengkang, we have not, because for our patient population, our Asian population are smaller, so we are a bit uncomfortable with leaving any abdominal aortic aneurysms more than 6.5, less than 6.5. Let's say if they're about 5 to 6.5, we would feel uncomfortable with leaving them alone. So these ones we still proceed and do them. So we haven't really followed their guidelines to the letter. Less than 5 centimeters in Sengkang, we would consider postponing as per usual. In terms of dialysis access, majority of them we will continue doing, because as I've said earlier on, this is their lifeline. So any thrombose access, obviously we'll continue doing. Any patients that need dialysis access creation, we will do them. Fistula revisions for ulceration, those at risk of bleeding out, we will have to do them. Tank of catheters we'll continue to do. Even malfunctions for fistulogram. At the moment, we are continuing to do this unless if the pandemic were to become worse, and I don't think it will become worse. But for the moment, the malfunctioning fistulograms we are continuing to do. Those AV fistula that need creating in planning, those we have postponed for the moment. Okay, so those who do not need dialysis at the moment, those we are postponing for the moment. In terms of peripheral vascular disease, acute limb ischemia, obviously we will continue to do it. Critical limb ischemia, those with tissue loss, we will do them. Anybody that needs fasciotomies, we will do them. However, those with rest pain, unless if it's really, really severe rest pain, we will consider postponing. Claudicants, definitely postpone, and we haven't done any for the last 4 to 5 months. Veins as well, acute iliofemoral DVT, only if is really symptomatic with phlegmasia, then we will do. That's about the only one we will do. IVC filter placement, symptomatic iliofemoral DVT will postpone if possible, treat them with warfarin. And the rest of them, May Turner syndrome for deep venous work, you know, for varicose veins, all those we will definitely postpone. So Singapore is a very strict country. So what happens if we do not comply? What happens if we perform non-essential services? So, you know, in terms of the circuit breaker, as you guys know, the government has been very strict. They've come down hard for those who flout the circuit breaker rules. And for us as a hospital, we do have to comply with the rules as well. So this is one example. I will not name which hospital this is from, but this is an example where the MOH felt that the hospital provided is an essential services, but they provided a service that was outside of the essential services. So they will write a letter to say that you have contravened the following provision, which is, you know, Regulation 10, essential services providers, what they are permitted to operate. And they do come and review our operations, and if they find anything which is outside, if you perform an operation which is not considered essential, then they will send you a warning letter. And in this warning letter, they will ask you to do one of three things. And in this instance, they will ask you to take steps to comply with the restrictions. In more severe cases, they may even ask you to stop carrying out the business or stop working at a premise and facility, which is obviously quite severe, or even to close or limit access to the premises and facilities. And they will give you a warning if you continue to if you fail to comply with this direction, and then they will say, you know, you're liable to a conviction, up to a fine of 10,000, even up to imprisonment for a term not exceeding 6 months. So it is treated quite seriously. The next thing we do is, if they're considered essential, then we risk stratify them into either high risk or low risk. Essentially, if it's high risk, then we wear the PAPR respirator, and I will show you what the PAPR is at the moment. And we do consider postponing this just for the safety of our staff. If they're considered low risk, by default, everybody wears N95. So how do we risk stratify? We risk stratify on the basis of history, whether they've got any symptoms, fever, respiratory symptoms, any family members or close contact with above symptoms, any contact with suspicious or confirmed cases of COVID-19, and of course, if they have had any travel history, especially to high-risk areas. If they're considered low risk, these are our precautions. Everybody, all the staff, we will have to wear N95 masks in the operating room, and that's been going on for the last 3 months already. For high-risk cases, then we take extra precaution. We use the powered air purifying respirator, and the PAPR looks like this. We use the Halo system. And to be honest, this, for me, for a longer operation which lasts 4 hours, this is a much more comfortable system than the N95. To be honest, the only trouble is that when you breathe in and out, you can't really hear anything because it's actually quite loud. That's the only real problem. Okay, lastly, I want to go on to what we do for patients with suspected COVID-19 or confirmed COVID-19. What do we do with this? And these are the patients that, for example, appendicitis, acute limb ischemia, they need the operation. We cannot postpone. We have mapped out a route, and there's a special OT which we reserve for such cases, and that's OT 3.4. This is a blueprint of our surgery on 3 in Sengkang. And normally we bring them to the preoperative area. However, for confirmed or suspected COVID-19 cases, this is off limits. We obviously do not want these patients to mix around with the other patients and also potentially the staff. So they follow this corridor down the yellow arrow, straight down the corridor and straight into OT 3.4, which is our designated operating theatre, designated specifically for COVID-19 patients. All these patients, these are our attire, you know, the surgeon, procedurist, anesthetist, circulating nurse, all those that will come in close contact with the patients. We will wear PAPR, we will fully gown, and we will wear face shields. For the rest of the runners, they wear N95, radiographers, runners, and other people in the operating theatre. Before we send for the case, we must make sure that the surgical team and the operating room is ready before we send for the patient. Then we send to the patient straight to surgery on 3, received by the AU and circulating nurse at the handover point. They don't go to the normal receiving point. We bring the patient straight through into the induction room. We park it in the induction room, and there's a mechanism, a strict workflow for where the patient goes through. We have strict barricades to prevent people from walking into the corridor, which is specifically designated for COVID-19 patients. Barricades like this to make sure people don't accidentally stray into high-risk areas. And at the end of the surgery, we do not bring the patients to a recovery room. We recover all patients with COVID-19 or suspected COVID-19 in theatre itself. When they are reviewed fit for discharge by the anesthetist, we discharge them straight to the ward, hand over to the ward by a phone with a certain extension number. And in terms of our PAPR, what do we do with our PAPR afterwards? Now, we have to be practical. All our PAPRs are obviously reusable. We only have a certain limit, a certain number throughout the day. So we do clean them at the end of it. It's the responsibility of the person wearing it to clean them. After using it with alcohol wipes, place a mask and harness in a specific box, and then they will then be sent to CSSU for decontamination, and they'll come back to us again. In terms of our disposal, we use an orange bag for all our COVID-19 cases. So all goes into an orange bag. And this is an infographic of to summarize our plan for patients with COVID-19. This is just our OR 3.4. The surgical team comes through here, they scrub up, they enter the OR from here, they gown from here, and then when we finish, we also have a specific workflow, and we do not deviate or do something different. So we all follow this quite strictly here. So this is my last slide. Thank you very much for your attention.
Thanks, Eddie, for interesting talk. Maybe I'll just ask one or two questions at this juncture. Really like the acronym for your Wuhan Task Force, WTF, is really WTF this period. I'm just curious for the PAPR usage. My understanding was that we invoke the PAPR for aerosol generating procedures, but you seem to suggest that all high-risk patient, and I assume that would be the COVID positive patient and the suspect patient, and you would use the PAPR. What is the rationale behind that? Eddie? Yeah.
Eddie, I think you're muted. You need to unmute yourself.
Yes. Okay. Sorry. There's no specific rationale. It's just something that we felt, we have enough of the PAPR at the moment. And also, we came as a group and we discussed which ones should we use them. I gather, everyone will, every institution will do different things, for aerosol, for example, in aerosol generating procedures, then you do them. But in our case, we do have enough PAPRs here, and we find that at the moment, with the number of COVID-19 cases we have here, there is no need to, be so strict on the use of PAPR. So we felt that, for all our high risk or confirmed cases, we should use them.
Right. So Chao, for your side, what are you also using PAPR for COVID-19 patients?
So for PAPR, we only use it for suspected or confirmed COVID-19 patients when you're handling the airway, so the aerosol generating procedures. So as you remember in the picture just now, the procedures was only in N95. The MICU team handling the airway was in PAPR. And the reason being that, when the system is locked in, when you have a closed circuit anesthetic unit, actually there's not much risk. That being said, I think the PAPR that Eddie has is more comfortable than the ones we have in GH. So probably that's why they have less barrier. The GH ones are a little bit more forbidding at the moment.
Right.
And to be honest, if I have a long procedure, most of the surgeons here agree, actually for the purposes of comfort, we really rather be on our PAPR rather than on N95 for 2-3 hours.
Definitely.
What about Dr. Lim in interventional cardiology? Do you guys also use the PAPR routinely for the, I guess, the
So,
suspect or the COVID?
So in interventional cardiology, we don't use PAPR mainly because we just use the full PPE, and in Mount E because there are already patients with COVID-19 as well that's transferred from the public hospital. The hospital is pretty strict on PPE use, and all the staff that's scrubbing for the case would be by default on full PPE.
Right.
And I think in the ICU setting, because we also have patients in ICU, in the ICU settings, the anesthetist, if they were to tube the patient, if there's aerosol generating procedures, if PPE is not available, they'll just use PAPR.
Right. Okay, I'm just watching the clock. I see 3 questions on the Q&A, but they are PCI questions. So I think we will wait for Dr. Lim to finish the talk and then we will go through those questions. So Dr. Lim Min Han is interventional cardiologist with Mount Elizabeth Medical Center. She used to work in Tan Tock Seng Hospital and in fact was the director of the cath lab there. She still is a visiting consultant to Tan Tock Seng as well as National University Hospital. So without further ado, Dr. Lim, please share with us your talk. I think she'll be speaking on the changes in patient population and disease pattern, as well as the implications for care.
All right. Thank you, Professor Tay, for the kind introduction. I'm here to talk about changes in patient population and disease patterns and implications for care, particularly for patients in cardiology. I'm going to review 2 papers that was published recently within the past 2 weeks, and I think that these are excellent papers that will highlight some of the questions and difficulties we'll face as we move on to phase 2 of of our COVID situation and the opening up. Now, while reviewing the current evidence, I need to remind everybody that there is great international variability in terms of disease progression, preventive measures, testing strategies, diagnostic capabilities, access to care and treatment, and variability in outcome reporting. The first the first paper I'm going to present is COVID-19 and thrombotic or thromboembolic disease, implications for prevention, antithrombotic therapy, and follow-up. This is published in Journal of American College of Cardiology 2 weeks ago. If I go back, it is a paper that is sponsored by 5 cardiology societies and written by 50 international investigators. It summarizes a lot of the case reports that has been, and a lot of the trials and studies that have been published within the past few months. As we manage patients, the first thing we look at are the common lab abnormalities in patients who present to us in emergency as well as on the wards. I would like to focus on hemostatic markers first. Thrombocytopenia occurs very frequently in COVID patients. Next, we will be looking at D-dimers. D-dimer elevation may be non-specific, and if D-dimers are elevated, it may not necessarily equate to the development of pulmonary embolism. However, if it's high and in patients who are very sick, it may actually be very late in the progression of the disease. And definitely, very high titers of D-dimers may mean poor prognosis for the patients. Markers of myocardial injury or troponins are often seen to be elevated. Again, like D-dimers, they may be non-specific and elevated in patients with renal impairment, elevated in severe sepsis and pulmonary embolism as well. It may be a result of myocardial thrombosis. And again, the interpretation of elevated troponins may require the use of bedside imaging like 2D echocardiogram to help us decide whether this is acute coronary syndrome or whether it's myocarditis. And if troponins are elevated, the prognosis is poorer for patients with COVID-19. And the third set of lab abnormalities would be markers of disseminated intravascular coagulation. Fibrinogen levels are not commonly done, but if it's checked, it would be initially elevated but decrease as disease progresses. But certainly fibrin degradation products indicate that the patients may have developed DIC, especially in the presence of decreased platelets. Now, COVID-19 infection results in a hypercoagulable state and may predispose patients to both arterial as well as venous thrombosis. There are multiple risk factors that we need to be aware of. If the patient's really ill, bedridden, obese, and has multiple background risk factors, including liver disease, kidney disease, lung disease, or pre-existing malignancies, these are risk factors that predispose the patients to hypercoagulable state. In fact, in the paper, they looked at autopsy findings of 79 patients in which thrombotic phenomenon was very frequently seen. In fact, thrombotic phenomenon was seen in the microcirculation, particularly in the lung and the liver in the hospitalized patients. The thrombotic phenomenon is also seen in undiagnosed deep vein thrombosis and pulmonary embolism in these patients. These are some of the studies that were looked at in the paper as well. I just picked out some of the pictures. On the top left would be a patient who has severe COVID-19 pneumonia and showing the presence of a clot in the pulmonary vessel. In the bottom left is a patient with ischemic limbs in severe COVID-19 pneumonia. And on the right is the patient who underwent thrombectomy, showing us the abundant thrombus that was removed during thrombectomy for patients for this patient which suffered leg embolism. Thrombotic phenomenon can also affect solid organs. As you can see on the left-hand panel, there are wedge infarctions affecting the kidney as well as the spleen in this patient. And mesenteric ischemia or gut ischemia can also be seen on these for these two patients, which shows CT findings of generalized bowel distension, segmental thickening, which are shown by the arrows, and adjacent mesenteric congestion. And in these patients, there is a small amount of ascites. All these findings may be non-specific, but they are suggestive and highly suggestive of early ischemia or gut ischemia caused by thrombosis of the mesenteric vessels. There has also been multiple reports of intracerebral arterial thrombosis resulting in large cerebral infarcts. And the article discusses three groups of patients, which I shall go in briefly to discuss. The first group is patients with venous thrombotic disease, and the next group would be patients with disseminated intravascular coagulation. The third group would be patients with acute coronary syndrome. The management of this group of patients with venous thrombotic disease, the most important part is establishing the risk. Ultrasound may be done, and in some centers, ultrasound is routinely done for all patients with COVID-19 infections. In fact, the prevalence is 15 to 30% of COVID positive patients showing thromboembolic disease, and the risk factors, as what I've mentioned before, would be bed-bound patients, obese patients, or patients with background risk factors. Now, there are three groups of patients we need to think about. The first group is patients with COVID-19, but no evidence of venous thrombotic disease. And the decision to be made is about the prophylactic treatment of these patients. And obviously, there's a general reluctance unless thrombosis is demonstrated. And at least in Singapore, I do know that ultrasound of the lower limbs is not generally routinely done unless clinically indicated. However, autopsy findings show that the incidence of venous thrombotic disease is high, and even if bleeding rates are low, I think we should review the data and decide on how to offer prophylactic treatment to patients. Now, the second group of patients are those with COVID-19 and discharged and due to be discharged, and the issue being the use of low molecular weights or NOACs, which is for prophylaxis for this group of patients. In overseas centers, they recommend the use of low molecular weights or NOACs for at least 45 days post-discharge. The third group of patients we need to think about are COVID-19 and patients diagnosed with venous thrombotic disease. And looking at the choice of drugs for treatment, low molecular weight therapy is the first, low molecular weight heparin is the first choice because of the ease of administration and the low bleeding complication. There's an absence of need of monitoring and the ease of dose adjustments in renal failure patients. Unfractionated heparin can be used in some centers, but it requires intravenous use, monitoring, as well as is related to high rates of bleeding compared to other agents. And of course, there's the issue of heparin-induced thrombocytopenia. And of course, if the patients are really unstable and unwell or has bleeding tendencies, IVC filters can be considered. And for those who are hemodynamically compromised, we have performed catheter-based interventions for these patients. This is the second group of patients that the paper discussed, which is patients with disseminated intravascular coagulation. And these patients with disseminated intravascular coagulation, as I said before, hospitalized patients without DIC should get prophylaxis to prevent DVT or pulmonary embolism. But in this paper, they looked at 4 different groups of patients. The second group is chronic patients who have chronic therapeutic anticoagulation, but if they develop suspected or confirmed DIC, we have to weigh the risk of anticoagulation versus the risk of bleeding. And again, this has to be an individualized decision. The other group of patients they looked at was patients on dual antiplatelet therapy who developed DIC, especially if it is within 3 months out from having an interventional procedure. In this group of patients, very interestingly, the paper actually gave recommendations on what to do depending on the platelet counts. If the platelet count is more than 50,000, they would continue the use of dual antiplatelet therapy. If the platelet count is between 25 to 50,000 in the absence of bleeding, generally they would recommend dropping 1 antiplatelet therapy. And if it's less than 25,000, we will stop 2 antiplatelet therapy. And that is to control the risk of bleeding. Again, we await randomized control trials regarding what is the right recommendation, but all these may be individualized decisions based on patient profile. The last group of patients that are with disseminated DIC would be patients who present with bleeding and low platelets, low fibrinogen, and elevated FTP levels. In this group of patients, even though low molecular weights heparin, for this group of patients, low molecular weight heparins may not necessarily carry a significant risk, even in therapeutic dose. Thus, if the incidence of pulmonary embolism, if pulmonary embolism is suspected, and because the incidence of pulmonary embolism in these sick patients is very high, if the bedside echocardiogram diagnosed RV dysfunction, or if the CT shows presence of pulmonary embolism, we may even decide to use antithrombotics or even lytic agents to treat these patients. But of course, we have to balance the benefits of treatment against the bleeding risk when we treat this very ill subset group of patients. The next group of patients that's discussed by the paper is thrombotic disease thrombotic disease, including ACS in COVID-19 patients. And generally, even up to now, we should defer non-essential services defer non-essential services because we need to conserve resources as well as protect our healthcare workers from unnecessary exposure. However, the treatment of ST elevation MI is still, the standard of therapy is still primary PCI. Now we'll talk about the last group of patients, which is the cardiovascular manifestations of COVID-19. of COVID-19, 1/3 of patients with COVID-19 will present with troponin elevation. There are multiple reasons for this. It may be due to demand ischemia, maybe due to myocarditis or direct viral effect. But whatever it is, when troponins are elevated, this generally translates to a 5 to 10-fold increase in mortality of these patients. What's more, myocarditis may overlap with ACS, and therefore bedside echocardiogram is essential to assist in the diagnosis in differentiating between myocarditis and STEMI patients. Some patients may present with acute heart failure, and as the initial presentations, a little like Takotsubo, when the virus, when a patient develops viral myocarditis. But arrhythmias are also very common. In fact, there are two issues here. The patients may have primary arrhythmias, usually reported as tachycardias or ventricular arrhythmias, but sometimes arrhythmias may complicate the treatment we give for COVID-19. For example, some of the drugs like hydroxychloroquine, azithromycin, all these may prolong QT and result in arrhythmias. The mechanism of myocardial injury has been, many mechanisms has been proposed. Could it be due to viral myocarditis, maybe due to cytokine-mediated immune injury, and severe hypoxemia secondary to alveolar injury, as well as angiotensin converting enzyme 2 related myocardial damage have all been proposed as possible mechanisms of myocardial injury. Not all events that we see with for patients in COVID-19 are due to thrombotic ACS. In fact, there are two studies, one published by the Lombardi group and one by the New York group, that looked at patients presenting with ST elevation MI to the cath lab, undergoing coronary cardiac catheterization, and showing that in the Lombardi group, 39.3% of the patients had non-obstructed obstructed artery, and in the New York group, 33% of the patients had non-obstructive coronary artery disease. So this highlights the difficulty of diagnosis and treatment for patients with COVID-19 who present with ST elevation MI, because myocarditis can sometimes mimic ST elevation MI. However, despite all that, most of the patients that present do not have COVID-19, and the standard of care is still primary PCI, because primary PCI reduces mortality by 30%, reduces reinfarction rate by 60%, reduces intracranial bleed by 90% as compared to thrombolytic therapy. And in addition, it shortens hospitalization. Now, one other problem that we realized ever since the COVID pandemic started was that patients have delayed their presentation to the hospital whenever they develop chest pain for fear of getting COVID-19. And so there were global reports of missing STEMIs, and in the local context, most of the hospitals here have also reported an initial decrease in the number of primary PCI cases. And together with these reports of missing STEMIs, there has been reports of complications of delayed presentations of STEMI, and including in this case, for example, this is a ventricular septal rupture. There has been cases of ventricular rupture, papillary muscle rupture. So the patients turn up later and sicker. And the paper also finally looks at another group of patients with thromboembolic disease but without COVID-19. And in this case, it illustrates that the progression in terms of medical practice, where we progress to using available technology to optimize patient follow-up while protecting both patients and healthcare workers. And that many hospitals have come out with protocols for telemedicine to monitor the patients, especially those that are chronic and stable. For example, the subgroup of patients requiring monitoring of INR. In some of the clinics, they have even suggested switching to NOACs or low molecular weight heparin for these patients. So that concludes the first paper. The second paper that I'm going to present also has a big impact on how we manage the patients with COVID-19. And in this is an imaging paper which is published in Circulation just last week. It looks at the spectrum of cardiac manifestations in COVID-19 patients. This is published by Tel Aviv Hospital University in Israel. It is a small series, but it is a very important paper, which is why I'm presenting it. It is the first systemic echo evaluation of consecutive patients, 100 consecutive patients who required hospitalization for COVID-19 and who then had a full echo performed. Of this group of 100 patients, 1/3 of the patients had a normal echo, while 2/3 did not. The most common abnormality seen is right ventricular dilatation and dysfunction, and this is observed in 40% of patients. The next common abnormality that is seen is LV diastolic dysfunction, seen in 60% of the patient, and LV systolic dysfunction, as what we discussed as in myocarditis, however, is only seen in 10% of the patients. So this two show the 4-chamber view of the same patient before and after deterioration, and you can see the significant decrease in ejection fraction as the patient deteriorated. So in patients with COVID-19, those with elevated troponin T occur in the incidence of about 20% of all patients, and these are the patients who have worse prognosis. This is another patient that this is an ultrasound of the femoral artery and vein. On the left, the femoral artery is compressible, and you can see the non-compressible nature of the femoral vein because of the presence of a large clot. This is the 4th-chamber view of the same patient, showing following deterioration, showing an enlarged RV as well as decreased RV systolic function. So according to the paper, approximately one-fifth of the patients got worse in the hospital, and the most common finding was further right ventricular dysfunction, followed by, if the patient deteriorates further, LV systolic and as well as diastolic dysfunction. And out of those patients who developed RV failure, 5 out of 12 of them had evidence of femoral vein thrombosis. The authors then concluded that the most common finding was RV dysfunction, which correlates with either pneumonia or thromboembolic complication. And the real concern of LV dysfunction that we have is much less common, at only 20%. So this concludes the presentation. I'm happy to take questions.
Thanks, Singhan, for that very comprehensive review of that 2 articles. Yeah, so we have heard a lot about these thrombotic complications, but locally, I believe the prevalence or the incidence is not high. Maybe I'll start with Eddie. Do you see any of these thrombotic complications in the vascular patients?
Yeah, I mean, I share the same, and I was thinking exactly the same thing. We've all heard about the increased risk of clotting in these patients, but so far I've not seen any increase DVT or any increase in acute limb ischemia. But I suppose we are seeing a very small percentage of our community patients, in terms of who actually is COVID-19 positive. So, but we are seeing a lot of, obviously there are a lot of migrant workers with COVID-19, but we haven't seen them coming in with DVT or acute limbs. However, there are reports of, young migrant workers discharged from hospital, COVID-19 proven positive afterwards, who dies of thrombosis in the heart. So I just wondered whether, these are true manifestations of COVID-19.
Right. Inhan, what about yourself? From the cardiology side, any increase in prevalence or incidence of thrombotic complications in your patient?
So we have seen some incidences of venous thrombosis and also arterial thrombosis, but again, the incidence is not as high as as what was reported by New York and by France. I mean, these are the two places which has published most data on these. But having said that, the French patients, the French as well as the New York experience is way worse than ours. I was speaking to a friend who works in New York Presbyterian. Out of the entire hospital, 3/4 of the entire hospital is intubated COVID patients, whereas I don't think we have that many intubated patients here. So if we see a subset of patients who are really ill, maybe we'll be seeing higher incidence of thrombotic complications. But again, with 20,000 foreign workers infected and hardly anybody ending up in the hospital and none of them in ICU setting, I think we're looking at something slightly different.
Right. Chao, what about radiology side? Is a pulmonary embolism a common finding in these patients?
So very thankfully, we haven't seen a surge in pulmonary embolism that we need to provide catheter-directed thrombolysis. Now, off and on, I've heard of some of the migrant workers coming down with mild pulmonary embolism, but I don't think any of us have done any increased work with regards to catheter-directed thrombolysis in the pulmonary veins. Pulmonary arteries.
Okay, I'll just go to the Q&A panel. There are two questions, I guess, related to PCI workload and the, I guess, changes in workflow. So maybe Inhan, you can answer this one. Essentially, is there a change in the workload or pattern in diagnostic coronary angiograms and PCI in cardiology?
I think across the hospitals, both public and private, we're seeing a marked decrease in workload, whether it's for elective or for emergency cases. Now, initially, we were unable to explain about the emergency cases, why there was a marked decrease, but I think there's some pickup at this moment. So I hope that answers the question on coronary angiography. So
Right.
The second part of the question is about the percentage of office-based diagnostic procedures.
Yeah.
Okay.
What about the workflow changes? I mean, with the COVID pandemic, I mean, Chao and Eddie have elaborated on some of the measures they have to take to do those procedures. So in the cardiac cath lab, are similar measures needed or implemented?
Yes, of course. I'm sure that different labs can be able to give you examples of close calls in the early days of COVID. For now, anybody who comes in for emergent procedures, everybody needs to be in PPE. But generally, we try to test if the patient has symptoms of ARI to test whether they have the infection. But certainly, everybody needs to be in PPE. And there was also initial discussion on whether the lab itself is neutral pressure, positive pressure, or negative pressure. And we realized that most of the labs are neutral in pressure, because the important thing about positive pressure labs, especially in the hybrid labs, is that when aerosolization occurs, the people outside sitting in the control room are actually exposed and without knowing. So in order to avoid unnecessary exposure, we try not to intubate in the cath lab. We try to do things in controlled situation. The patient needs to be intubated. They're either intubated in the ICU setting or in the emergency department before coming to the cath lab. So these
Right.
are some of the procedures that we take.
Maybe just one final question for all three speakers. We keep being reminded that this thing is going to drag a bit. The new normal keep coming up in the vocabulary. So in your respective practice, what do you foresee as the new normal? Maybe we start with Chao first. What would the new normal look like in IR?
So the new normal is going to be mask every day. It's going to be me eating lunch at least 3-4 meters apart from the colleagues. And it's also going to be I think there may be repeated lockdowns, and I think certainly in the IR center we're trying to gear towards that. And I think definitions will change as well when it comes to as the profile of our infected patients change, the way we screen patients will change as well. And we're going to have more Zoom meetings, I'm quite sure.
Eddie, what's your take?
Masks will be here to stay for sure. Social distancing, no more really eating lunches together, which is a bit sad, obviously, but that's the way it is. No more really going out to have drinks really afterwards. Well, sounds quite depressing, really. But this is unfortunately the new normal, and I can see it going on for at least 1 to 2 years, maybe. I hope not forever, until we find a vaccine or a really effective treatment for it. In terms of our workflow, I think we're gradually seeing us opening back all our services. I cannot see us
lost the signal.
Okay, maybe I can talk while waiting for him to get connected.
Right, yeah, maybe,
Yeah,
yes.
okay. So for us, new normal, unfortunately, may prolong until the end of the year, which is rather sad because you can't meet up with friends for lunch. But the good thing, of course, is there are lots and lots of webinars to attend without having to drive there or even and give webinar talks without having to change. So okay, but in terms of patients, I think for us in Mount Elizabeth Hospital, at least in the private sector, and maybe some of your private patients in the public sector, you're not going to be able to see foreign patients easily for the near future. Yeah, so that is the new normal. Yeah, and I think we'll have to start with teleconsult at some point. That's going to be a new normal. It's a little bit difficult, especially in cardiology.
Right. Sorry, Eddie, we lost you there for a while. Yeah, I think I'm just watching the clock. We have passed 7:30, so times is up. Remains for me to thank all three fantastic speakers for a very interesting evening. I certainly have learned a lot. And I also like to thank Philips for organizing this webinar. So good night and stay safe, everyone.
A very big thank you to our speakers, Dr. Tu, Dr. Chok, and Dr. Lim. We appreciate you being here. A special note of appreciation definitely to Prof. Tay for helping to moderate this webinar. And thank you everyone for joining us today. We will see you next time. Thanks.